This episode of PediaCast CME is brought to you by Nationwide Children's Hospital and Widening Impact in Medicine and Science, also known as WIMS, at The Ohio State University College of Medicine. Hello, everyone, and welcome to another episode of PediaCast CME. We are a pediatric podcast for healthcare providers. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 116. We're calling this one Navigating Fertility Issues in Medicine. I want to welcome all of you to the program. We are so happy to have you with us. Fertility challenges are a common but rarely discussed issue for medical professionals, much higher, in fact, than the general population. And I was not aware of this, and I think that many of you out there may also not be aware of the frequency with which infertility occurs among medical professionals, and we want to raise awareness about that. Those of us in healthcare play a key role in supporting folks through difficult times. Many of us do that every day. But in addition to providing support, sometimes we need support. And one of those areas of needing support is infertility treatment. Medical trainees often face delayed childbearing, restrictive leave policies, financial pressure, and demanding training schedules, all of which drive up the risk of infertility. Today, we'll explore how infertility impacts those of us in medicine, and we hope to spark conversations and solutions that support medical professionals now and their families later. Of course, in our usual PediaCast CME fashion, we have a terrific guest joining us in the studio to discuss the topic. Dr. Cristiane Ueno is a plastic surgeon and associate professor of surgery at Indiana University. Don't forget, after listening to this episode, you can claim your free Category 1 continuing medical education credit. It's really easy to do. Simply head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes. Click that link to Cloud CME and then click on the Materials tab after that. Taken past the post-test and the Category 1 credit is yours. We offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And it's because Nationwide Children's is jointly accredited by all of those professional organizations that we can offer the credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of this episode matches your scope of practice, which this is another one of those that really pertains to everyone as we think about increasing awareness about the ways in which infertility impacts medical professionals. Complete details about the CME are available over at PediaCastCME.org. Also want to remind you the information presented in every episode of our podcast is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. Also, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. So let's take a quick break. We'll get Dr. Cristiane Ueno settled into the studio, and then we will be back to talk about infertility challenges faced by medical professionals. It's coming up right after this. Dr. Cristiane Ueno is a plastic surgeon and associate professor of surgery at Indiana University. She has a passion for raising awareness and providing support for medical trainees and her colleagues and peers with regard to fertility challenges during medical training and a subsequent career in the health sciences. As we will discover, health learners and practitioners face an increased risk of fertility challenges, which can be quite stressful as we balance work and family. That is what she is here to talk about, navigating fertility issues in medicine. Before we dive in, let's offer a warm PediaCast CME welcome to our guest, Dr. Cristiane Ueno. Thank you so much for joining us on the podcast today.
Thank you. Thank you so much, Mike. Thank you very much for this opportunity. I think this is a very important topic that has a special place in my heart because I suffered a lot of what we will discuss, including fertility issues and ultimately decide for the adoption route. So
Yeah.
I hope we'll bring awareness and more people will not have to go through what I went through.
Yeah, absolutely. Definitely something important to consider. Can you kind of lay the groundwork for why thinking about fertility is a critical topic for medical trainees and, in the case of our audience, pediatric providers, and not only from the woman's perspective, but also from the family, from societal perspectives too.
Yeah, no, thank you, Mike. I think we are doing a phenomenal job in background work in terms of recruiting more female to the workforce in medicine in general. So we have an increased representation of female in medical schools, medical students, residents, and physicians working. However, one thing that sometimes we forget to look into is that the medical training actually happens during the peak of reproductive years for female, that is between the age of 20 and 35 years old. And that can create a strain on childbearing abilities. So medicine, it's a giver's work and has a professional environment that can be demanding, long hours sometimes and high stress levels. So we might not know going into the field or into the field, but physicians have a higher rate of infertility. So one in every four physicians will experience infertility, whereas in the general population, this number is between 9 and 18%. So I think that knowledge of low fertility rate among physicians, medical students, trainees, it's very important. So I appreciate this opportunity.
Yeah, absolutely. I was going to ask about, current research in infertility risk in medicine. As you mentioned, there is an increased risk. What kind of research has been done to show that there really is increased risk that's statistically significant among healthcare workers and trainees?
I am a surgeon, so I am involved in our society in terms of some numbers within our society, but it's all across the board. So in 2023, JAMA Open published, and this is actually referenced in this podcast, the U.S. general population infertility is about 6 to 19%, where we discussed. And then they surveyed female physicians, not only surgeons, and they noted a 36.8% infertility rate. So in that survey, there were over 1,000 women that were surveyed, but not only trainees. On the survey, 26.8% were fellows or residents, but 7.6% were faculty and 60% in non-surgical specialties with 45.2% in academics. So 78% of those surveyed were able to identify the correct age of fertility decline, and three-quarters of the surveyed physicians, they delayed their family building because of their career. And out of those 36.8% that presented with infertility, more than half went through IVF. So, and what is really shocking is that in that study, 45.7%, which is almost half of the surveyed female, said that they have family building regrets, and which is very unfortunate. There's also in the PediaCast a study that was done in 2025, so it's a recent study by the American Society of Reproductive Medicine. And then the prevalence of delaying childbearing for your first child. For physicians, it's about the age of 32 years old. That's the average. Whereas non-physicians is 27 years old. So that obviously decrease the chance of fertility. And I think those are shocking numbers, but very important to understand.
Yeah, yeah, absolutely. So let me just kind of sum up to kind of get it straight in my head here a little bit. So if we look at fertility rates across a large group, the entire population, we get a number. And then when we look at infertility rates among women physicians, we see a much higher number that's statistically significant that's been published. Do we think that that is happening because of the delay and then the increased risk of infertility because you're starting to try to have a family later? Or is there something intrinsic about medical training that, increases your risk of infertility beyond just it being an age issue? Does that make my question make sense?
Yeah, absolutely. Absolutely. I think it's both. The answer is really both. So, according to the American Society of Reproductive Medicine, there has been an overall in the population an increase in birth rate for women that are older since 2021, which is not just for the physicians but the overall population. But still, again, the mean age of a first child for a physician is 32 years old as compared to 27 for the non-physicians. So the majority of the times in all surveys, and the numbers are very similar. So in general, the peak of your training coincides with the peak of your childbearing age. So that is one factor. There is definitely a delay in family planning because of career choices. And some physicians will, choose, there's a difficulty with trying to identify practices that will support reduced working hours or, extended leave in medicine. So those are kind of extrinsic factors. But also, there's the risk of the long hours, the stress of the job, burnout. Those unfortunately lead to decrease in fertility. I personally was not aware of that when I tried my fertility journey. I was 35 years old, and I was not aware that, I was going to have problems with fertility. We have these numbers in our head that when you become 40, that's when you are higher risk of complications for pregnancy. However, the age is actually 35. And so I was like, well, I'm 35, I'm 5 years from be 40, so I'll be okay. And that was not true. And then when I checked, my ovary reserve was very low. And when I asked my mother had a completely different experience. I asked my sister. My sister had children at age of 33 and 36. So she had no problems as compared to me. And I think that, again, it relates to the long hours, the stress of her jobs, and that corroborates for this difference, like in my family, for example. So this is something that we should be aware of.
Yeah, yeah. And I would say not only be aware of, but also to maybe do something about.
Mhm.
And it's one thing to say, okay, we're going to make everyone aware before you apply to medical school that this is going to increase your risk of infertility moving forward. And I think we can clearly say that with the numbers. And so I would say that with anything that's a risk factor, you can either just avoid the risk factor or you can try to decrease that risk in some other way. And I think we have to choose the second of those options because otherwise we would be discounting a whole group of folks who would make excellent, compassionate physicians and help other people. And if we just turn them away from medicine because of that risk of infertility, we would really be doing a disservice to patients and families down the road in the future. So if we sort of establish that this is something that we need to not be quiet about and to try to do something to improve those risks, first, I guess, why is it that this is not something that folks talk about?
I think it's lack of knowledge, honestly. And not only lack of knowledge from the trainees and physicians, faculty, but also in our leaders. There was a publication of a survey that was done in the Women's Health Report Journal in 2021 that surveyed program directors, for example, and then over 50% of them had no idea about insurance coverage for fertility treatment. 70% of them had no idea of, you know, coverage for fertility preservation treatment. And the a lot of them, the vast majority of the program directors, were not aware of their residents going through fertility issues. And I would say not only female trainees, but also male. During my time at Ohio State, I had male trainees that were going through fertility issues. So don't think that it's just a female. Obviously, the childbearing age, the peak for female, it's in the 25, 29 years old. But men at age of 45, they start to have decline. So essentially, the male trainees, they have a later peak. However, they also go through decline. And I think this is important to understand as well, because it's something that is not just cis female, cis male, but also transgender population. So it's something important.
Yeah, 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 for sure. So lack of awareness is one. I would think another reason that folks, when you said a lot of program directors don't even know their trainees are going through any sort of infertility treatment, in that sense, it would seem like, for one, it's personal, but also you may have fear of the consequences of you sort of rocking the boat when you need to take time away from your training program to undergo infertility treatment.
Yeah, unfortunately, this is correct, right? There's really no established policies in terms of time off for treatment. There's really no very well established policies for even grief if you suffer a loss, for example. And in preparation for this PediaCast, I was looking into some data, and what I found shocking too, Mike, is that paid parental leave is not federally mandated in the US. So, during this research, I also found, which I found very interesting, is that 42% of the medical schools don't have paid parental leave. And there's 44% that don't even have paid parental leave for faculty that, for example, go my route, that is the adoption route as a non-birth child, which happened to me as well. My husband works for a organization company that is not related to medicine. He had 10 weeks of parental leave, whereas I did not have because we didn't, it was a child that we adopted.
Yeah.
So
Yeah.
this is important.
Are there things that can be done so obviously decreasing the stress is helpful, and there have been movements toward that. When I think back to my own training, we had every third night call, and you could sometimes work 100 hours a week, and those that kind of situation obviously needed to be corrected for many reasons, and has been, but but it's still very stressful on the body for sure. So we can try to decrease that stress as much as we can within individual programs, but still meeting the needs of individual hospitals and patients, and that all that gets very complicated. Are there also some things that folks can do to increase the likelihood that they'll be able to have a family later on? I'm thinking things like egg preservation and that. Can you talk a little bit about what that entails? And then we'll also think about the cost of that and how does that get covered?
Yeah, that's a very good question. I think, we are 100% making progress, right? And again, having this opportunity, like if you imagine when you and I went through training, probably there were not, there was nothing about this. So I think those are great. And we see more and more programs that are family friendly, which is very, very important. So I think, and then the other thing that is important too is that in 2013, the American Society of Reproductive Medicine changed the technique of egg preservation from experimental, so took the name away, which actually helps with insurance coverage and also helps with awareness. So there's an opportunity to have egg preservation, which means that you may not be able to have a child during your peak of fertility. However, what you can do, you can actually save those eggs and then to use them in a later date. There's an option to do the egg preservation, but also the embryo preservation, which means you basically inject the sperm in the egg and then save the embryo for a later date. So those are ways that we as female or even male or even, like I said, transgender populations, we can also preserve the ability to have a child in a later age.
Yeah, yeah. This is okay. So this is completely out of the ballpark for me in terms of thinking about as a pediatrician and as a man, both. It's a little more difficult to wrap my head around this. I had no idea they did frozen embryos. I've heard of, frozen eggs, but a frozen embryo, is there any side effects of being frozen as an early embryo, like later in life?
Yeah, no, absolutely, absolutely, absolutely true. I think there's things that are important. So if you have the age of the egg is extremely important, right? And then there are probably risks related to the frozen embryo that, we cannot predict. Keep in mind that I'm a plastic surgeon. I am not an OBGYN, so I can't really say the chances per se, but those are opportunities, right? For example, one of my previous partner, they were a gay couple and they wanted to have a child. So they did the embryo freezing. And then later in life, when he was established and was a faculty and they had a better, let's say, economical situation as well, they opted for a surrogate and the embryo that they had frozen in the past. So those are options, and not only for female, but also for male.
Yeah, yeah. So the bottom line is talk to your fertility specialist about these things. And we certainly on this podcast aren't advising every female who starts medical training to have a frozen embryo set aside. But it's something to think about, as you said. And the first step of that is raising awareness about possibilities that we may not even have brought up with our own medical professionals because we didn't know about this risk factor. And so just, getting the word out so folks start thinking about it critically, not only on a personal level, but also on a program level, because if the program is a known risk factor for fertility issues down the road, is there a way that programs can be more friendly to making sure that the insurance that they have covers that's one thing. Another would be if you need time off to do these things. So I do wonder, like, that makes it more difficult and challenging to talk about. But I really don't have any idea of how much time is needed for those kind of treatments.
I think I went through IVF during my training and I did the wrong way and by not letting people know that I was going through that. So I don't even know if I would have had a chance to have time off or not because I was scared of disclosing that I was going through that. But it's really the time to go get blood drawn, which we can cover for each other, or you don't need a day, or two. You just really need a couple of hours. So I would say probably a little more flexibility in terms of timing. Maybe be, instead of being, for me, I was in surgery, so instead of being surgery, be in the clinic, for example, where you have more support for that period of time. So I would say having this conversation with your program director, or with your, if you are junior faculty, with your chief, with your chair, and try to make them also aware that you're going through this, because there's also an emotional toll. But you just need a few hours, right, to go get a blood drawn and ultrasound and things like that.
Yeah, yeah, yeah. And having those open conversations ahead of time is going to make it much easier. And hopefully, folks have empathy and understanding and realize the importance of this. And again, I think the more we talk about it, the more awareness that we have. And then that will, hopefully help those who are having this issue down the road.
Yes, 100%. I think so. Don't go through that alone. There's support. Even though, for example, on the research about program directors not being so much aware of the resources, the majority of them, uh, almost 100% of the program directors said that they were supportive. They could offer emotional support. They could make adjustments. And I think that is true for everybody.
Yeah, yeah. When you go through something like this, it really does become passion for you to get the word out about this, so that others can feel support and sort of know where to go, and how to, what path to follow based on maybe the mistakes that you feel like you made and could have done in a better way. And one of those is to talk about it openly and seek that support. Some programs, though, may not have a champion like yourself, and it would be nice to have some conversations about this before it becomes an issue, so that you have, so that you can provide that support that folks need, and to have understanding of, the kind of time commitment that's required, and how you can find that time and cover for each other, as you said. For those programs, would you recommend, if someone's hearing this now and thinking, oh, we have never talked about this, really anyone can be a champion for it, male or female, right?
100%, absolutely. When I was at Ohio State, the program director with me actually is a physician at Nationwide Children's, and he was fantastic about it. So I think that i- the more we talk about it, please don't feel that I never went through this. I don't know what it is. I don't know how to talk about it, right? I think this PediaCast offers an opportunity. Maybe you can play that around. There's data that we are putting out there for people that are joining us today or will join us later, that they can actually look into those numbers and offer that as resource. I think it's a matter of offering a safe space. And then you'll be surprised how people will come to you and they will actually disclose. During my journey of speaking up, because again, the choices that I made, I would totally have made differently if I had an opportunity. So I had medical students coming to me and say, I'm worried, what is egg preservation? Or should I have a family now? I had residents in this journey. I had junior faculty coming to me and talk about it. So I think the more you talk about it, you'll be surprised and people will come and see you as a resource. And that is fantastic, right? That's what we're aiming for, to have more and more resources and be able to create a safe space for everybody.
Yeah, yeah, yeah. So very important. I also want to point out there is a little bit of a difference, I think, and please correct me if you think I'm wrong about this, but there is a difference between the kind of support you might need if you are going through a short residency program, like a general pediatric program or a family practice program. If it's 3 years, and then you're going to be younger when you start to think about having a family. And so, but in the surgical specialties, and as you had mentioned, those were the highest risk. they're also the longest training programs often. So, you do a general surgery and then you do your fellowship. And the next thing you're 8 years out of medical school before you really feel like you have the time and opportunity to start a family. And you may want to start a family sooner than that as you get into those longer training programs. And so, before I feel like I had was speaking a little nonchalantly, like, oh, it's, we can't you just wait until after the program, which you may be able to do if it's a 3-year program. But the longer surgical residencies and fellowships, this does become more of an issue and probably more so than we know because folks don't talk about it.
Yeah, no, I agree. And I think, having the opportunity of the egg preservation, embryo preservation, understanding IVF. For example, for me, as I was going through I started with intrauterine insemination, which for me was a very low yield that I was going to end up with a pregnancy. But I was not aware of other possibilities. So when I started to become aware, then I asked my GYN at that time, and I said, "Why can't I just jump into IVF?" And that's when I figured out that I had a low egg reserve. But there's also, an opportunity for an egg donor, surrogates, and things like that. But more so, let's say you get to the pregnancy, right? As you said, because of the longer training, most likely you're gonna be a older parent, your egg's gonna be older, you'll be like almost like a geriatric pregnancy, right after the age of 35. So then your risks related to the pregnancy are much higher. So your chance of having problems with preeclampsia, right? Your chances of having a child of, low weight at birth or having to go to a premature labor are much higher. So there are studies in there actually for female surgeons, which is kind of shocking too, because in the survey and the surveys that I'm talking about, so 42% of the female surgeons suffered a pregnancy loss. And then 84.4 were in the first, 10 weeks. However, 3.8% were stillbirth. And that's something that unfortunately is extremely sad, takes in a huge emotional toll, and we need to be aware and understand. A few months ago, I had one of my colleagues, plastic surgeon, that actually suffered a pregnancy loss. And she basically said, I was barely aware that I was pregnant, so this can be quite traumatic as well. And like you and I, we don't want to dissuade anybody from any career. I absolutely love what I do. But again, having the knowledge and the opportunity to make that decision, it's extremely important.
What are some concrete things that programs can do that can make a measurable difference in this?
I think it starts with education from both ends, right? Education to your trainees and your faculty, but also education to the leadership. Because if the leadership education will lead to change at the institutional level, change in the policies, and change in the culture. And then you educating your trainees, educating your faculty will actually bring awareness of their options. So this definitely, it's one of the most important things that we can do. I think that, having a strong institutional support to combat infertility is extremely important. Other is consider, flexibility in hours. Of course, it's an ask from all ends is childcare support in terms of insurance for fertility, treatment coverage, and also for fertility preservation. So not only support for the IVF treatments, but IUI treatments, but also for egg preservation. So insurance coverage, definitely some better policies in terms of parental leave or in having some maybe policies for people that are going through those treatments as well. There are lots of things that we can do, Mike. I can go on and on.
Yeah, yeah,
Uh,
yeah. And the first step is raising awareness, and then from a program director standpoint, like to think about this as an issue before it becomes an issue. So sort of, lay the groundwork for this, someone wanting to do egg preservation or go through IVF treatments, to have the groundwork laid before the person arrives so that we can provide support, and help them have a family later after their training or during their training. How can we use going through something like infertility challenges to help us be a better physician in terms of how we engage with patients based upon that experience?
I don't want to say that makes you more human because that's not true, but definitely from the start makes you a little more empathetic. And I think not only, but again, you don't have to go through this, right? Just having the awareness will definitely help you with that. And you may identify even in your patients, right? You may have a family that is going through this, and by you showing your vulnerability, you may open the door for them to explain to you. And for example, when I take my daughter to the pediatrician, she's adopted, and I'm always a little worried. It's like, oh my gosh, they're gonna ask about family, medical history and things like that. And as she grows up and she's with me, I'm always a little worried. How do I say that? How do I explain that I have no idea of those things? I think going through this, or like, as we are aware, there's higher risks of having other physical complications or even organic complications related to late pregnancy. So having that awareness definitely helps you support the parent as well that are coming to the visit, not not only the child, and maybe understand them a little better.
Yeah, yeah. Yeah, it definitely increases empathy, but as you said, just raising awareness about we would rather have a positive experience for our trainees than to say, "Well, it was negative, what can you get out of it?" Like, let's make it positive right from the get-go. But certainly, you have taken your experience into your practice in terms of empathy for patients and families, and that is a real thing, but, not to the degree that, well, then it's okay to let folks go through the stress and, issues that accompany, infertility treatment during training programs, right?
Yeah, and I think, the good part is that as you are aware, maybe someone is going through this next to you, and maybe it will be easier for you to catch up on that and kind of like, help help your colleagues and offer a hand, offer a shoulder, give a hug. And I think that the most important thing is create this family friendly environment and decrease the stigma that because you want to have a family or because you want to get pregnant, that doesn't mean that you want to be a less of a physician or you're less committed to your professional life or your specialty. By all means, that's not true. And I think the more we do that and the more we support others, the more of us will be out there, right? And then less of my stories or less of other sad stories will be out there. And that's the ultimate goal for everybody.
Yeah, yeah. And you could say that same thing about so many issues that oftentimes we have good causes, but advancing those causes is gonna rock the boat. And so if we don't say anything, that is certainly one option. But, not only are you doing this for yourself, like if you're in the situation where you do have to advocate for yourself and say, "This is important to me and I wanna be able to do it," and, openly talk about it, that's gonna be an important thing for folks, not only for yourself, but then also for those coming behind you, that you really are paving the way for it to be easier for subsequent trainees. And, that's a really important thing and can make the discomfort of rocking the boat maybe worth it a little bit more.
Yes, I think so, 100%, right? You already seen those changes, right? When I started my journey, I could not get any fertility coverage through the insurance provided by my training. However, I was lucky enough that my husband could get through his work. So we got some coverage. And now we see that more and more there's coverage, right? Same with, lactation rooms. In the past, you would not see that. And now we see more. There's some societies that have meetings that are very family friendly. They are half a day and then the other half is your family, or there's child care into the meeting. So I think there's more and more. The more we bring awareness, the better it gets. And we're making progress. I agree with you. We're making progress and making things better and better. And hopefully one day this PediaCast is going to be, oh my gosh, this is old age. This is for the
Yes.
dinosaurs. And this problem doesn't even exist anymore, which is the ultimate goal.
Yes, yeah, absolutely, 100%. We can talk about norms and how norms are contagious. And so, the norm has been to just wait till after your training to start a family. The norm has been, oh no, we have to do all these long hours. The norm is that we can't do those things. But, as we've seen when things do improve, it is because someone bucked the norm. And the more that we do that and push back against norms, the more that we can create norms that make a lot more sense.
Yeah, I agree with you. If you think about simple things, right? In the past, you would not think that, wearing a seatbelt would become a norm, right? Or wearing a helmet or even recycle, right, will become a norm. And now it's a norm. So I think that we have this idea that changes are impossible and big changes such as that are impossible, but it's not. Just look around us. Like I said, recycling a few years ago, if you talk about recycling, people will be like, oh, how are you going to convince all this, group of people, which is essentially everybody, to recycle? And now everybody does it, and we do it without even thinking. So 100%, we can totally rock this boat, make this change. And I so hope that this conversation will be for the dinosaurs pretty soon.
Yes, yes, absolutely. Well, this has been a great conversation. I'll be honest, this is probably the most difficult PediaCast CME that I have recorded in recent memory. And that's why I feel like I've been sort of all over the place with asking questions a little bit, and certainly not in the order that we had discussed previous to the podcast. But I think it's these sensitive issues that sort of take us off guard because we didn't have awareness about the issue. And so anyway, and to the audience and to you, I apologize that I have not been 100% with this with this topic, but it is not as black and white as many scientific topics that we discuss. When you inject that element of humanism, it becomes more difficult, but also very worthwhile to talk about for sure.
Yes. Yes. And honestly, I don't have words to thank you for this opportunity. And, thank you, Maya Aubrey, for this great opportunity because it's something that is a little bit of taboo. There's some stigma around. So this will involve, some culture change, but it starts with us. And as you said, I hope this is be something that will be so contagious that will disappear. And maybe, one day it's going to be so simple as talking about recycling or
Yeah.
wearing your seatbelt.
Yes, yes. We are going to have some terrific resources in the show notes for folks. So if you head over to pediacastcme.org, episode 116, look for the show notes for episode 116, and you'll find these links. And they really do go into lots more detail about the situation and with thinking about infertility during training and what we can do about it. The first one is from JAMA, Childbearing, Infertility, and Career Trajectories Among Women in Medicine. We also have one from the Permanente journal, Family Planning, Fertility, and Medical School, a survey of students' plans and perceptions of institutional support. again, right in line with what we've been talking about. Also from Women's Health Reports, fertility preservation and infertility treatment in medical training, an assessment of residency and fellowship program directors' attitudes. NIH has a resource page on infertility and fertility resources. And then isolation, discrimination, and feeling constant guilt, a mixed methods analysis of female physicians' experience with fertility, family planning, and oncology careers, and that is in the journal Cancer. So we'll have all of those links, and I'm sure that if you did a Google Scholar search or a PubMed search, you would find lots more on this topic, and we're just, again, trying to create much more awareness here so folks understand the situation and what a lot of the trainees do face. That's not as infrequent as you would think because people don't talk about it, but we want to start talking about it. And then I think you'll discover that it is way more frequent than you otherwise would have thought. And hopefully that's the message that we were able to get out today. So once again, Dr. Cristiane Ueno from Indiana University, Associate Professor of Surgery, plastic surgeon there. Thank you so much for stopping by and chatting with us today.
Thank you so much for this opportunity. This was great. I appreciate you.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast CME a part of it. We really do appreciate your support. Also, thanks again to our guest this week, Dr. Cristiane Ueno, Associate Professor of Surgery at Indiana University. Also, thanks to our co-sponsor this week, Widening Impact in Medicine and Science, also known as WIMS, at the Ohio State University College of Medicine. So this is our last episode of 2025. We do have a full schedule for you, though, planned for 2026. So we will be back. But I did want to take time out again just to say thanks for all your support. We really do appreciate that. It means so much. And, I have folks, reaching out through the contact page on social media in the halls of the hospital, just saying, hey, we love the podcast and appreciate you taking time to do it. And I just want to say thank you all for taking time to listen. It's really much appreciated. And I hope that you have really great, fantastic holiday with family, friends, and loved ones. And, those of us in medicine often work over the holidays when other folks are off. Please try to take some time out for yourself and take some getaway time if you're able to do that. It's just so important to recharge and refresh. And the holidays are a great time. I do want to remind you can listen to this podcast wherever podcasts are found. We're in the Apple Podcast app, Spotify, iHeartRadio, Amazon Music, Audible, YouTube, and most other podcast apps for iOS and Android. Our landing site is PediaCastCME.org. You'll find our entire archive of past programs there, along with show notes for each of the episodes, our CME information, our terms of use agreement, and that handy contact page if you want to reach out and say hello or suggest a future topic for the program. But just saying hi is fine as well. Reviews are also helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Instagram, Threads, LinkedIn, X, and Blue Sky. Simply search for PediaCast. So you have listened to the podcast. Now be sure to claim your free Category 1 continuing medical education credit. Really easy to do. So head over to the show notes for this episode at PediaCastCME.org. It's episode 116. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME. Click on the Materials tab. Taken past the post-test, and the Category 1 credit is yours. It is super easy. And again, we do offer credit, and it's free credit to many pediatric professionals, including physicians, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. Complete details are available at PediaCastCME.org. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.